Thank you for that introduction. First of all, I wanted to say it's a great pleasure to be here at the HIT Lab Summit and be part of the innovation. And I do want to thank Dr. Stan Kachnowski for all the work he's been doing and kind of really inspired me to be participate and be part of this group, as well as the others in the HIT Lab team for organizing this event. So I've been a practicing physician for almost 30 years and also been in the healthcare leadership in the different opportunities over the years. And currently been serving in James Lovell Federal Health Center, which is an integrated DoD VA facility in North Chicago. And I oversee the medicine directorate, which comprises of the medical surgical unit, ICU, emergency department, as well as oversee the medical affairs. So I wanted to share with you some of the experience with managing strokes with the use of telehealth, specifically tele-stroke programs. So as you know, during COVID last few years, there was a really increasing use of telehealth technologies to provide care for our patient, to improve access to care, and to improve quality of care. And stroke is an area where really it helped, I think, improve the access and quality of care. So what I'm going to do is first talk about kind of overall stroke in general, then talk a little bit about the telestroke programs, and then go into some of the experience at the VA as well as outside. Some of the evidence and studies done and show how it has been helping improve the care. And then lastly, I'll touch on some of the emerging technology, AI, for improving stroke care. So can you go to the next slide? Okay, so in terms of the background, stroke is really the number 5 cause of death in the United States, and it's the leading cause of disability in the US. And again, stroke can happen to anyone at any time, at any age. So it's really important to know the warning signs of stroke. At every 30 seconds, someone in the US has a stroke, and every 3 minutes and 14 seconds, someone dies of stroke. There's over 800,000 strokes happening in the US every year and over 150,000 deaths. And majority of the hospitalization, over 75%, occur in older adults, 65 and older. Also, there's an increased risk of stroke in a lot of the minority or underserved populations, as well as in African Americans and Hispanics as well. And they also shown that African American Black are more likely to die from stroke than other racial groups. So there's certainly some racial and ethnic disparities in stroke care. And hopefully telehealth will help address some of those as well. In terms of the cost, stroke related cost came to about $66 billion in 2015 and is really rapidly increasing with the aging population and increasing risk factors. And by 2035, this is supposed to go to, anticipated to increase to $142.9 billion. And of that, the proportion, 81 billion for non-Hispanic whites, 32 billion for non-Hispanic blacks, and 16 billion for Hispanics. So it's really an increasing burden of cost in the healthcare system related to stroke. Now, and this data is from CDC, American Heart Association. The barriers, there's certainly a lot of barriers to getting timely care for stroke. And one of the barriers is a long travel time to get to the specialized stroke centers. And when stroke happens, it can happen very quickly. And if you can't get to a stroke center timely, you may not be eligible or be able to get the care you need. The second thing is patients don't arrive necessarily within that travel window of being eligible for treatment. And the third thing is really overall lack of availability of stroke specialists for these patients who are having a stroke. Next slide, please. So as I mentioned a little bit earlier, so timely identification is really critical when it comes to stroke identification and care. And so we're emphasizing, in terms of prevention and early treatment, is really emphasizing that time is brain. And just like people go for chest pain, we have been, over the last several years, there's been more encouragement for patients to seek stroke care immediately. So for every hour treatment is delayed, the brain can age by over 10 years. And 1.9 million brain cells die every minute. The stroke is untreated. So early treatment has been shown to increase the survival rates and also lower the disability rates. And so that's really critical when it comes to stroke care. Now, the burden of stroke is borne by not only the survivors, but the family and caregivers. So it's certainly a big issue. Now, according to the 2019 study, only 37% of the patients arrived at the hospital within 3.5 hours of symptom onset, which is the window to get the treatment with like TPA. The other issue is the demand for neurologists exceeds the supply. And hopefully with tele-stroke program, it'll help us fill some of that gaps in care. They've shown increased mortality rate in rural areas related to lack of timely stroke care. In addition to rural residents, American Indians and low-income patients also have to travel greater distances to stroke centers, leading to higher mortality and worse outcomes for stroke. So with that background, I think the importance will go into how the tele-stroke programs can help get better access to specialty care for these patients. Next slide. So this is really a mnemonic kind of to help for a quick symptom recognition for stroke. And the initial mnemonic was FAST, which is basically looking for facial asymmetry, arm weakness, or leg weakness, and then looking for changes in speech, slurred speech, or difficulty speaking. And if any of these things are present, to activate 911, or if you're at the facility, to activate the stroke team. Now, over the years, they've added BE along with it, and that's shown to kind of capture more stroke patients if you just use FAST versus BFAST. So that includes balance problems like dizziness, loss of balance, ataxia. And then also looking for vision problems like blurry vision, double vision, which are also signs of stroke. So with these, allows for a more rapid recognition of stroke and getting timely stroke team activated and treatment activated at the health center. Or if patient presents to the emergency department, or if they're hospitalized and develop stroke symptoms. Or they could be at a nursing home as well. So for every 15 minutes, you can treat faster for every 1,000 patients. 4 lives can be saved, 18 more can be improved, and can walk home on their own after the discharge, and 7 more will recover from their home afterwards. So next slide, please. So next, I'll go into telestroke programs. So majority of the strokes you have are due to, are called like the ischemic strokes, which means they're caused by blockage of the arteries, versus a hemorrhagic or stroke, which is ruptured arteries. So over 80% are from ischemic blockage. And so for these types of stroke, intravenous thrombolytic therapy or the clot-busting drugs are shown to be the most useful, but they have to be administered within the 3.5 to 4 hour window. And that is really critical for patients to benefit from this treatment. Also, patients who have a large vessel stroke can benefit up to 24 hours with the endovascular treatment like thrombectomy, but that's something which is typically administered at a tertiary care center where they have an interventional specialist who can do this kind of procedure. And those can help benefit those patients with up to 24 hours. So the key here is recognition early of patients who may benefit from TPA and also who might benefit from the vascular intervention. And some of this can be treated locally and also deciding which patients need to be transferred out versus just transferring everybody out or which is not a more efficient way of use of resources or time, or doesn't benefit patients either. So, as I mentioned earlier, many patients who are eligible may go untreated due to lack of vascular neurologists when they present to the hospitals, because sometimes these decisions can be not very clear-cut. So you need a specialist to help make that decision, in a lot of cases at least. So telestroke programs really is a part of telehealth, which is enabled access to specialized consultation for patients presenting with signs of acute stroke. Next slide, please. Oh, actually, can you go back to the previous one? Okay. So, so the way it works, the telestroke program is patient presents to the facility, local facility, and that could be in an emergency department typically, or they could be in a urgent care or an inpatient unit or a nursing home. And then patient experiences acute stroke type symptoms, and as I mentioned with the VFAST, they're having those symptoms that will typically lead the staff to activate a stroke team, and then also assess if the patient is eligible for a TPA or endovascular treatment. And then that would then also activate the telestroke neurologist consultation. So the neurologist is typically connected through a video, like an iPad or video with the primary team. So the primary team is connected remotely with the vascular neurologist, who would be on the patient will be on the screen, and they're able to evaluate the patient. But the primary team is doing the actual examination in the room with the neurologist. And then they also would typically have access to medical records and the CT scan, and would review the scan, medical records, and then advise the primary care team regarding diagnosis and treatment. And at that point, then the CT scan is typically done before, right away after the stroke team is consulted. And once the result is back, then the decision is made if the patient is eligible for TPA, then that can be administered locally. And then if they need to be transferred, and that can be initiated, or they would be admitted locally if the hospital has an ICU at the local facility. Next slide. So this is kind of an example of a telestroke equipment. And as you can see at the top, there's the iPad, and there's a speaker in the middle, and a equipment tray where you put all the required equipment for the exam. and then there's a power source. So again, there are different companies have come up with various equipments over the years, can be used. At our facility, I was talking about James Lovell Federal, we have a ICU and inpatient unit, but we are not a tertiary facility, so we actually use telestroke program in our facility. And we have vascular neurologists at other tertiary VA facility whom we connect with, and we have actually used it for the last couple of years successfully. And this iPad will face the patient in the unit, and they're able to then interact with the specialist. Next. Okay, so I'll go a little bit into the VA program. It's called the National Telestroke Program. And the reason it was created was to help deal with the disparities in stroke care, and especially with the rural veterans who did not have access to timely stroke care. And over 3 million veterans are struggling with access to care in the VA. And also, these patients, veterans, are at higher risk for stroke due to increased comorbid conditions such as hypertension, diabetes, obesity, smoking, and other factors. So this was certainly, we thought this would be useful. And it was started in 2016, and now it's expanded over the years. It started with only a limited number of facilities, 10 facilities, and it's increased every year, and now we have 67 facilities participating across the country. And they're linked to about like 20 or so neurologists who are also scattered around the country, and other specialists who are typically at the tertiary centers. Now, so these veterans could be at the ED, urgent care, or even inpatient unit. One of the requirements is really the facility should have an in-house CT scan so you can get a rapid result, which is important to make a decision regarding stroke. So it's really been very successful over the years with the program. And a lot of the private sector as well, large groups have been using telestroke successfully. So next. So I pulled the evidence on telestroke to see, what is the data to support the care. We were talking about value-based care, and I really looked at the evidence, pulled up the literature on telestroke to see what benefit has it shown so far. So, and I'll show, again, these are just, I put these together quickly, so it's not very fancy, but I'll go over some of the evidence. One of the programs now in the VA, the telecare, the stroke, one of the studies looked at these controls versus patients who are getting telestroke program. And they showed that 14.3% patients were more likely to receive TPA who are in this program, and 4% patients are more likely to get thrombectomy. So there's evidence for more guideline-based care. So this is not only in the VA, this has been shown on the outside as well. The next thing, there was also a telestroke implementation in rural areas and has shown better outcomes compared to usual care. And integration with pre-hospital and in-hospital settings could optimize the emergency stroke approach. So there's a study looking at reviewing over 19 studies involving over 28,000 patients in the rural areas, showed that the telestroke programs successfully increased the proportion of patients who were getting a timely care, proportion of optimal treatment at 3-hour time frame with the odds ratio of 2.15, and better 3-month outcome of 30% better outcome. And the telestroke was also associated with the shorter onset of treatment time, so 27 minutes earlier treatment, and lower in hospital mortality by over 30%. So significant benefit shown in these studies in the rural areas in particular. So the other study showed telestroke hospitals reported 30-day mortality was significantly reduced in patients with telestroke, and TPA administration in rural areas was improved by 55%. So really getting those patients get a TPA administration locally was very important and has been useful. And also is shown to decrease the disparity in stroke treatment. Next. I also looked at additional data at the VA with telestroke program. And one of the areas we looked at was the decrease in emergency department transfers. So a VA study of 50 sites were participating in telestroke programs analyzed over 3,400 encounters. And some of them were pre-telestroke, and then about 2,400 were post-telestroke. And they showed a 14.4% decrease in the ED transfer, and also about 60% reduction in the odds of transfer. So what it means is we're helping with the more accurate diagnosis of these patients and avoiding unnecessary transfers. So for patients who can be treated locally or they don't really have a stroke, they don't need to be transferred. So that's been helpful in terms of transferring the right patients and actually help decrease the cost and the burden also of transferring patients to the tertiary care centers. In addition to that, we also looked at patient satisfaction data. Patients who received, there was a study looking at the their interviewed patients 2 weeks after the telestroke encounter. And there were like 186 interviews conducted at the VA facilities. And 76% reported satisfaction with telestroke. And some of the factors associated with patient satisfaction were higher rates of technology, but also telepresence, which means the presence of the health care providers, as well as the communication ratings were important. So overall, I would say the telestroke has really helped improve the quality of care, patient satisfaction, and also, as per the recent information published by AHA, in 2019, stroke was the leading cause of Medicare admissions, accounting for 20% of Medicare admissions in the US. And telestroke has shown to reduce the hospital costs by over $2,200 per patient after accounting for costs related to TPA and setting up the telestroke networks. So telestroke has been there for a number of years and continues to expand. So what I wanted to say was really still there's a lot of opportunity because patients are still not getting the timely care, even though large health systems such as VA has shown a lot of benefit with this. But overall, there's still a lot of opportunity, not only in the US, but even abroad. American Health Association is actually advocating three things. One is ensuring coverage for telestroke by third-party payers. Secondly, really ensuring that all trained providers who are eligible for telestroke care are able to help in the telestroke care by having simplification of the licensing programs, as well as decreasing network restrictions to enable these providers to participate in care, and also encouraging the development of more simpler, streamlined, less expensive technological options, which will help improve the telestroke even further. Now, in the VA, one of the advantages we have is this federal supremacy, which means you can practice across the state lines. So that has actually helped us a lot with these specialists being available across the state lines. Last slide I had is, I was just reading up the literature on telestroke, and I kind of came across this article on artificial intelligence in stroke care. So I thought would mention that. With the AI, there's certainly potential to further improve and revolutionize the stroke care. And to help with more rapid and reliable diagnosis through image analysis, there's been, in some of the places I've been using, including the VA, we're using AI to help screen these images. So for example, one of the things we've done is AI can help screen the scans which are positive for bleed, and then they will show up at the top of the pile. So then for confirmations, if you have bleed, you can get TPA. So it helps with rapid triaging and screening these patients. That's an example of AI use. And also intelligent EMRs can help free text and provide rapid decision support, analyzing charts, getting the information together when the patient presents in a very rapid manner. That can help improve the stroke care. Also, speech recognition has been helpful with kind of putting the diagnosis and documentation as well, where you have the speech recognition help capture the events and document them as they happen. So there's certainly, with AI, there's also smart, contextually aware communication can be improved with the use of AI. So these technology hold immense promise in enhancing not only the clinical experience, but improving the outcomes as well at a lower cost. So as we go forward, we're looking forward to using how can we use these AI and emerging technologies to further improve care, and also continuing to expand the use of telestroke and improving the technologies which are involved as well in the stroke care. So that's all I had this morning. Any questions?